deals with diabetes mellitus. This is intimately related. H1C, though many of you may have diabetes in your family, or you know somebody suffering from family, they usually do H1C and fasting and PP blood sugar. So I will tell you a little bit more. So diabetes, just like thyroid book I told you, big books are there only on diabetes, and there are good number of journals, and the lecture hall will be full. The entire big lecture hall will be full with the journals. Why? Because diabetes is a very common disease, very common disease. But believe me, it's a poorly understood disease, and that is the reason it is just like blind man describing an elephant. That's why so many books, so many theses, so many journals. A disease is poorly understood. Even after reading this book, you will not understand, but rather it will invite some more questions. As if as you are going up, your horizon will go on expanding, and at one point of time you will not see the horizon at all. So it's not that easy. Many persons self-proclaimed persons tell that I am a diabetic specialist, I am blood sugar specialist. Nobody can cure. Diabetes is not a curable disease. Diabetes is a controllable disease. Now, I would like to say you at sometime in the middle, try to prevent the disease, and you can prevent. So this part I have shown it to you. Glucometer one day during glucose class. Again I will show you. I have told Regina to bring it. If she can bring, otherwise in practical class you will handle it. I will bring my own glucometer and show it to you. So this is a very easy method. Many persons use it at home. Only thing that it needs to be properly used. You read the literature thoroughly and then do the procedure properly. Mistake is here. Glucose in blood, it is blood glucose basically, it is not plasma glucose the way it is done in the laboratory. Remember, this we are pricking here, collecting the blood, and that blood glucose is analyzed here. In the laboratory, we collect the plasma, and from that plasma we estimate glucose. So in the literature, try to find out whether the glucometer is plasma calibrated or not. Means it will draw the blood, whole blood, but it will take into the account of plasma factor, that is 45% packed cell volume, 55% plasma. So with that factor will be there. So they will multiply simply with that factor. So you will get a near plasma glucose level. One thing is important I want to highlight. You are collecting blood here from the capillary. Capillary is a mixture of venous and arterial blood. But in the laboratory you are drawing from the vein, and there will be substantial difference. In the fasting state, since the blood glucose level is at the lowest level, so ideally there will be hardly any difference between the two, because tissue will not be extracting that much amount of glucose. But during postprandial, means after meal, blood glucose level will be high, and it will be drained through the artery in the capillary system. In the tissue, the cells will extract glucose, and the area which will be drained by the vein, this glucose concentration will be lower. You understand? In the fasting state, if you draw blood from a finger prick using a glucometer, if you draw blood from the vein, usually there will not much difference. But after PP, if somebody does this from here and at the same time from here, there will be a remarkable difference depending on the degree of diabetes. The more the diabetes, more the difference. More the normal, the result will be almost same. Near that difference will be say less, because suppose somebody is having a blood glucose level, plasma glucose level of 300, somebody having 400, somebody having 500 BP, and somebody is having 100, 200, 150, 200, or 150, or 120, 110. So in this case, if you will get 110 from here, at the best you will get 100, not more than that. But those who are diabetic, having a 300 plasma glucose from this place, You can, if you prick it, you might get 220. Or 300 here, 220 here. You don't know. You really don't know. So this cannot be measured. What you can do is that while you are drawing the sample from the vein, you put a drop from the syringe into this and send it to the laboratory. That result will match because the sample is same. And it will be, if you do it properly and the glucometer is calibrated properly, the strips are also correct. I have seen there is practically no difference, but that has to be done very correctly. That's the point what I want to say. During in the laboratory, you will draw the investigation for blood sugar. You will send it to the laboratory. Laboratory will give the report in the evening, maybe afternoon. But you want to know blood glucose level, what is the blood glucose? Don't give it to the nursing staff. You ask the nursing staff can draw the blood, or you can draw the blood and get the same sample, same blood tested in the glucometer, record it. Then you can, if you want to give urgent medical treatment, you can give, or you are having a baseline value, you can cross check with the laboratory also. And periodically you can have a go take the this glucometer to the laboratory. That is the reason why I have spent a little amount of time on this. So proper use of the machine is to be known. So plasma glucose is a standard laboratory method. It is done by blood glucose, but most of the glucometers are plasma calibrated. That particular what you try to find out from the literature, or ask the supplier whether it is a blood glucose or it is a plasma calibrated. Do you get my point? Is this part clear? Whether the glucometer is plasma calibrated or not. If it is not plasma calibrated, then the value will not match. Blood glucose level will be lower. If it is a plasma calibrated, and if you draw the same sample, it will give almost the same result. That part you must know. So this part you know, this anemia, thalassemia, this term glucemia. Mia means it is present in the blood. So glycemia means presence of level of glucose in the blood. Glycemia. This particular term you must say, so that you understand that you are a medical person. So glycemia means presence of glucose. Hypoglycemia means, hypo means low. How the terminology has come? Normoglycemia. You say normal blood glucose, don't say normal blood glucose, don't never say glucose, never say sugar, glucose. Normal plasma glucose level. So normoglycemia, instead that you better use this one, normoglycemia. The patient has not yet achieved normoglycemia. Patient is still hyperglycemic. Patient is still hypoglycemic. We want normoglycemia to be obtained. That's the target point. Blood glucose, blood sugar, plasma glucose, plasma sugar, forget about this thing. So diabetic mellitus patients suffer from hyperglycemia. You just note down this definition. So it's basically a common group of common metabolic disorder that share the phenotype of hyperglycemia. Just write down this one. Ideally, you have to remember this part. So diabetes mellitus is basically a group of metabolic disorders characterized by hyperglycemia and diagnosed by the following. Bhalo kore shono na. This try to understand in a breath. You just tell plasma glucose, fasting more than or equivalent to 126 means if it is 126 or more fasting blood glucose, it is diabetes. PP more than or equivalent to 140. And HbA1c more than 6.5. I will elaborate on HbA1c. These three figures you must memorize and tell, at a stretch. Because you have to diagnose. What is fasting? That means there will be no calorie intake for at least 8 hours. This is standard written in the book, but I would suggest you advise for 12 hours to the patient, so that the patient will comply. Patient might make a delay, so 10 hours might be there. If you say 8 hours, there might be overtime 6 hours. So patient will try to, স্যার 1 ঘন্টা 2 ঘন্টা দেরি হয়ে গেছে, কি এমন ব্যাপার আছে, আজকে করবেন না কেন, এসব বলতে আরম্ভ করবে। So better ask 12 hours. Last night you see what is the actual blood collection time in the laboratory. See, if it is 9 o'clock, can you cover at 9 o'clock? Then you take the meal 9 o'clock or 10 o'clock, then the preceding night, so that you have a margin. That's what I used to practice. And 2 hours after glucose means 75 grams. Remember this thing, 1.75 grams per kg body weight up to maximum 75 grams. How the PP, postprandial after meal glucose is done, that is done by glucose, after glucose. And normally in an adult of more than 45 kg body weight, 75 grams is the, but less than 45 kg, you calculate by kg only, and then that measured amount of glucose is to be given. And this is the criteria for ADA to ADA. What is ADA, American Diabetes Association? I will tell you 25, and WHO 2020 criteria. This is the same criteria of diagnosing diabetes. So clinical features of diabetes. What are the clinical? One is polyuria. Polyuria means increased, poly means multiple times. So the patient will pass urine multiple times. Polyuria. Polydipsia, because urine is passed, so patient will feel thirsty. Why patient will pass urine? Because glucose will be present in the urine. It will exceed the renal threshold capacity. So glucose is a metabolic, this osmotically active substance. So it will draw water. It will try to draw water to remain in the solution, and that is the reason there is a more increased formation of urine. And the more the increased formation, the patient will want to go to the toilet. More the patient, this is the osmotic diuresis basically. Polydipsia. Polydipsia means there is urine volume loss, water loss, so patient will feel thirsty. Polyphagia means multiple times eating. See, there will be glucose in the blood, abundance of glucose around the cell, but cell will not be able to utilize glucose. The cell will not be able to take up glucose from its surrounding because of the disease process. So there will be actual starvation of the cell. So glucose, from the glucose we get the energy, so we will not get the energy. In starvation, there is a real deficiency because plasma around the cell, the glucose amount is less. But here it is just the opposite. The amount of glucose is around the cell is more, but cell is unable to take it. So end result is same. So cell is basically getting starvation, unable to produce desired amount of energy, and that is the reason that hunger mechanism will operate. We feel hungry because there is lowering of blood glucose level. That is the basic mechanism. And those who doesn't feel hungry and try to take food, they are going to gain weight because you are blunting that system. And most of the children of today, 1 or 2 child norm, usually they are overfed. Before they feel hungry, they are fed. So that system doesn't operate, and in course of time they become obese also. And it's very difficult to reverse this thing. So let the child be hungry, then you give the food. Or you feel hungry, then you take the food. It's a problem. It's a problem of the society. And that is the reason why we are having too many diabetic patients today, even in the early childhood. So unintentional or unexplained weight loss. Patient is not intending to lose weight because the high energy glucose is being lost through the urine. That is the reason weight loss is there. Unexplained weight loss, remember, diabetes is the first cause. Second cause, think of malignancy, cancer. Third is tuberculosis. in an otherwise normal individual, which you cannot explain that why the patient has lost his body weight. First, think of diabetes, which is common disease. Second is cancer. Third one is tuberculosis. Rule these three out first, and then think of anything else. Blurring of vision, because lens is suspended within the aqueous humor, and that is also having glucose. So it is getting the nutrition from the glucose. Now, if the glucose concentration is more, so lens will contract, shrink simply, because the effect is here, or the effect of glucose, high concentration of glucose is just like you are putting one grape inside a very thick solution of sugar. So that actually water will go out from that grape, that it will decrease in size. Same thing will happen in the lens. So there will be some amount of visual problem. So blurring of vision. Chronic recurrent infections, I will show you in the next image. Boils, abscess, delayed or improper healing. Just by looking at the wound, you will be able to diagnose that this is a diabetic wound. Asymptomatic. Remember, most of the patients are asymptomatic, because this disease process starts insidiously over years. So patient's body get adjusted to it. So therefore, that is the patient do not feel any problem, any symptom. So-called these classical symptoms are not present because the body get adjusted. And when these symptoms occur, believe me, the blood glucose level will be 300, 400 like this, fasting blood glucose. And PP blood sugar even 700, 800, even more than that. In a short while, you will see this thing. Patient do not remain symptomatic until unless the level is very high. So many of you, if you are having 149 students, if we try to measure blood glucose level, at least some of you, maybe 5, 10, I may be wrong. I wish to want to be wrong. Maybe having a slightly towards diabetes, or if not, you are not normal basically. Because honestly speaking, you eat more than you do the exercise, and your eating habits are not proper. So that is the reason, as a medical student, I would advise you get a blood sugar testing, fasting testing, blood glucose testing done yearly once, so that you can detect at a very early stage, and have a control over taking food, because once you develop the disease, honestly speaking, there is no cure. It's a lifetime friend or foe, whatever you say. So it is done during casual routine investigation. It is detected, and the patient usually shouts that I cannot have that much of blood sugar. I have this much blood sugar, I cannot have. It is the wrong report. He will move from this laboratory to that laboratory, and this laboratory which will give the lower value, he will accept it, which is not a fact. Presentation with complication of diabetes means since he was not symptomatic, so he did not bother to think of him. Complications have developed, and usually patient comes with diabetic cataract, or there is retinopathy. I will show you there is ocular hemorrhage. Already damage has taken place. Disease is quite advanced and it has caused complications. Or the patient is coming with a renal failure. Patient requires dialysis. I have seen this type of cases. Or diabetic ketoacidosis or hyperosmolar coma. Patient is first presentation is like this, because patient is not aware of it. He is coming with coma. Or he might have thought and he has taken other system of medicine, thinking that something it will be cured. No. So this is basically this type of infection you will get it. Once you get this type of infection, first rule it out whether the patient is having diabetes or not. Because if the patient is having diabetes, whatever treatment you give will not respond, and make sure, explain to the patient you need urgent control of blood glucose, and in this case insulin will be given temporarily at least to control the infection, otherwise you cannot. See the condition is a oral fungal infection. The oral fungal infection, the moment you put this thing, you will be able to diagnose the oral candidiasis. It doesn't happen normally in any individual diabetic patient. See the infection style, is infection, diabetic food. See the ulcer, condition of the ulcer, neglected ulcer, he has undertaken this therapy, that therapy. Now, even in women, because urine is, through the urine, high amount of glucose is coming. So, if you put a speculum inside the vagina, you will see the candidate infection just like oral cavity. A thick pus just like a card. And once you see a patient, you will never forget. Vaginal candidiasis, same thing will happen in the male person. Once you see this type of patient, think of that patient is having high blood glucose level. So, balanoposthitis, that is vulvovaginal candidiasis. This is genital candidiasis. If you find, first rule it out, diabetes, and invariably you will get it. So, diabetic foot. So, can you imagine? And you will see, here I have seen in the OPD. Neglect. Why this has happened? Because he has lost the nerve which is supplying the sensory, sensation has been lost, because sensory nerves have been damaged by the diabetic process complications, on top of which infection is there, and blood glucose is very high. So, that all these three has contributed to such chronic infection. So, infecting organisms are getting nutrition from that glucose, very high glucose. So, they are getting adequate in nutrition. So, they will flourish. So, the purpose of showing you just to clinically orient you, and once you see this type of cases, you will never forget to see diabetic gangrene, means the foot needs to be amputated. I hope all these things have not been discussed in a previous class. See, if you put an ophthalmoscope in the eye, which I have done, you can, if you bring, I will teach you how to do this thing. Even if you put an ophthalmoscope in retina, if you see there is a hemorrhage, exudate, there is a hemorrhage. The patient is having complications with the eye. Now, this is again you require a laser therapy. It's typical, microaneurysm is typical of this microaneurysm. Once you see, this is quite characteristic feature of diabetes. It doesn't occur in hypertension. In hypertension, this type of exudate you can get, but this microaneurysm is very specific for diabetes. And once you see a microaneurysm, you think that this is a diabetic cataract, diabetic retinopathy. So, microaneurysm is a characteristic feature of diabetic retinopathy and a hard exudate. So, criteria for diabetes, these criteria what I have given, that plasma glucose, fasting, PP and HbA1c. Basically, earlier when we were students, even I came to know about this thing when I was an MD student in the year 1988, to be precise in the third year, the WHO technical series, they published reports, and the first criteria was given in 1985. The cutoff limit was 140 fasting and PP was 200. Later, they published in 1994 also, the same criteria, 140 and 200. But 2020 guideline, what I have shown it to you, it is the same thing, that they have changed the figure. They have made, I'll tell a little bit about discussion. American Diabetes Association, they came into the picture from 1997, and every year in the month of January, they publish guidelines for diabetes management. So, they have written the plasma glucose, fasting and postprandial and HbA1c as the criteria. Okay. So, what I would suggest, that once you are in a 5th year class, see, this is WHO technical series report series. What today you can download it in the internet. It was difficult for me. I had to go to New Delhi National Medical Library to correct this one, because at that time in Durgapur this was not available. So, this book I collected, and this you can also diagnose. The WHO technical series report is 2020. This is available in the internet. So, what I told about American Diabetes Association, this is 2025. In the month of January, every year they publish the guidelines what will be the diagnostic criteria, what are the management guidelines. I would suggest that at least while you are in 5th year class, since all of you will be appearing in the NEET PG, and you will be also practicing in case you do not qualify, read at least the latest issue of this diabetes care completely. Make a note down the salient points, and in the next year, if you appear in the next year, only just open that book and see what are the new things that have been added in the January 20. Suppose this is January 26, 25, 26 you are appearing NEET PG. In the month of January, first job you do, you download it. It is usually available in the month of December on the preceding in the current year. Download it, note down, and 2 points you see here. One is criteria for diagnosing diabetes, and second one is criteria for pre-diabetes. Usually this point remains same. The footnotes you please try to note down. Questions might be there from these footnotes. And if you go through, this is the asterisk mark I have given. Now, this asterisk mark is basically from this place. This one, you see the asterisk mark. See the asterisk mark. See the asterisk mark. And usually there is a change here. And similar changes are there in multiple places. So try to note down what is the difference. I can tell you the difference, I will show you. See, ADA 25 guidelines says that diagnosis requires, you see here, the striking point here, fasting or PP or HbA1c. Or this, you go look, 2021 or means any one of the three. But if you look closer here, see this, what I have highlighted here, see diagnosis requires 2 abnormal results from different tests which may be obtained at the same time. Means 2 different tests, not all, at least 2. It can be fasting HbA1c or fasting HbA1c or fasting plasma glucose, or it can be HbA1c PP, it can be fasting and PP of the same test at 2 different point of times, or the same test at 2 different point of time. Means if you want to do fasting, today you do it, tomorrow you do it, or day after tomorrow you do it, same test. In contrast, if you look at that 2021 guidelines, see, diagnosis requires 2 abnormal test results from the same sample. Means you have drawn the sample, the result was high, and you repeat the test, you get a high value. So therefore, that is a diagnosis criteria. Or 2 separate test samples, what was written here. So these are the minor points, and confusion usually is there. So latest criteria is like this. You must be updated also. As a student of this college, I would say that yes, we are also updated. Don't think that you are from medical college or you are from all these 2 minutes, you know, I don't know. That's the thrust point for you. Okay? And if possible, you have a review of the last 10 years, what was the issue, what was the beginning, what was the actual criteria, so that during conferences, during interactions, you can elaborate. No, whatever I am telling, it was not like this in the original. There is an evolution. There is sea changes from what we have thought, knew earlier. So HbA1c is basically, now you note down, this entire thing you note down, this will be required for, this is the main area for you to know. So fasting PP or random means any time, whether regardless of the timing, if you draw a blood, that means you are drawing a blood at a given point of time. See, today you are collecting, it is right now, suppose it is 11 minutes 58 seconds, 11 hours 58 minutes 11 seconds. That is the point. So that gives a point of time, what is the blood glucose concentration. In contrast, HbA1c is a long-term assessment of last 10 to 12 weeks or 2 to 3 months. Why? This has become a fascination. HbA1c fascination, I would say, because all the clinicians are very much interested to get the HbA1c report. But from the HbA1c report, as I could understand, that you cannot decide the dose of the anti-diabetic medication. You would need fasting and PP. You can get an idea from HbA1c what is the average blood glucose level for last 2 to 3 months. But at a given point of time, what is the result? You don't know. So why? Because in an otherwise normal individual, otherwise means the patient is not that abnormal and suffering from other diseases. The RBC lifespan is 120 days. So that means it is nearly 4 months. So there is a continuous turnover of RBC productions. So during that time, there is spontaneous glycation of the hemoglobin, non-enzymatically, and that is what we are measuring. That is the reason it is past 10 to 12 weeks, because some fresh RBC will be there, some old RBC will be there, some intermediate part will be there, so you will get a mixture of RBC. Since they are having 128 days life, so somebody will be reaching 118 days, 110 days, some will be 100 days, some will be 90 days, some will be 89 days, because every day continuously production is going on. So glycated hemoglobin, this is HbA1c, this is glycation means non-enzymatic, and glycosylation is another terminology which is used loosely to say, mean the same, but glycosylation is an enzymatic process. You need glycosyl transferase. But glycated HbA1c is basically non-enzymatic and it is glycation. So depending on the blood glucose level, write down this part. Alpha amino group and N-terminal valine moiety of beta chain of hemoglobin is non-enzymatically glycated. It forms a skip base. Initially there is a reversible form called allevin, and if the level blood glucose is maintained for quite some time, then it gets converted into a stable form that is irreversible or stable ketamine form, that is called amyloid rearrangement. This I will show in the next slide. You remember somehow this much, this part of the slide. So HbA1c is a measure of beta N1 deoxyfructosyl component of hemoglobin. Somehow digest this thing just like a quinine tablet, at least as a biochemistry student. This part. So just like glucometer, it can be measured. There is an HbA1c meter, but it is not that accurate. At a bedside level, in the OPD setup, you can have this type of machine and you can get what is the HbA1c level. But the reference method is always HPLC. If you advise any patient, to ask them to go for HPLC, not for colorimetry or automated analyzer. This is a reference method. If the patient wants to spend money, ask him to spend a little more money to go for this test. Because this is a costly investigation, but it will give you a good result. Now these are deliberately arranging. What happens basically? See, this is the valine, N-terminal valine. With the ambient blood glucose concentration, there is basically this structure gets converted. This is amyloid rearrangement is there, and this is the ketamine form. This is HbA1c. This is what we are measuring. Suppose you have taken say 10, 12 Rasagolla today, and there is ambient sudden rise of glucose level, or even if day after tomorrow for 1 week you have taken. So there will be temporary elevation in this condition. Now if you go on taking this same type of diet, sweet, so blood glucose will be stable, maintained at a higher level for quite some time, and that will convert this part from this part, and that cannot be reversed. So diabetic patients who are poorly controlled, that means their blood glucose level were maintained for quite a long time, they finally undergo to this form, and that is what we are measuring. Is this part clear? So why HbA1c? Note down this part, only these two lines. So HbA1 constitutes 95% of Hb, hemoglobin. Out of HbA1, 85% is HbA1c. And most molecules belong to the group that is the maximum amount. Actually, what happens if you elute this thing, Hb in pure form, Hb0 is a major form fractionation. That constitutes the basically the HbA1, and this HbA1 of 95% is, so that is the reason maximum amount is there. আচ্ছা এবার দেখো এইটার দিকে দেখো এইটা তোমাদের মনে রাখতে হবে একটা সিম্পল ওয়ে আমি বার করে দিয়েছি সো HbA1c is given in terms of percentage unlike blood glucose it is in milligram per deciliter fasting blood glucose you see note down it is 126 milligram per deciliter pp 200 milligram per deciliter but it is in percentage so 6% is equivalent to average blood glucose of last 3 months is 126. Now, with each percentage increase, you add 28 or 29. So, you will get an average. Remember any one of the three, any one of the two, either 28 or 29. You simply add on to 126. Suppose 6, 8, so you have to add 2 into 28, 56. You add, you will get the figure. So, you will know what is the approximate blood glucose concentration of last 2 to 3 months. Now, this may or may not match with fasting on PP in a diabetic patient. বুঝতে পারলেন না? See, HbA1c we are measuring. Now, we have to report it. How do we report it? We report it as percentage. So, 6% of HbA1c corresponds to an average plasma glucose level of 126. Now, somebody is having a slightly higher blood glucose level, suppose this one, somebody's report is 12%. So, that means it is almost double. Now, what this 12% will indicate, how much blood glucose level is there. So, you have to add 6, here is 12, that means there is a 6 difference, 6%, 6 into 28 or 29 you multiply, the figure you will get and you just add 126 plus that figure, it will come to 226 to 98. Do you get my point? Just why I have added. So somebody is reporting 10% glucose HbA1c means that means the patient is diabetic. There is no doubt about it. And you see, this did not happen overnight, as I was explaining. Okay. Now, what earlier used to happen, I am telling you the truth. The diabetic patient used to have a fasting and PP blood glucose have. Now, most of the diabetic patients are very fond of taking food and sweets. In course of time, they become also clever. What they used to do in my professional life, I have seen on the preceding night or one or 2 days before the scheduled test, they used to decrease the food and used to increase their anti-diabetic dose. Okay, so reduction of food one part, anti-diabetic dose increase is another part, so both will decrease blood glucose level. And on the day of investigation, they will get a near normal report and they will say, I am having a normal report, near normal, I can now right now eat. And it's self-cheating. Even his wife, or if it is a wife or his husband, now you cannot take this much, but I cannot give you that food. My blood sugar is this much. Now this is a trick they used to adopt. Now this can be diagnosed. Suppose you are having a fasting plasma glucose, you are showing it is 112 and PP you are showing it is 156. In contrast, HbA1c is 11%. So that means what you have done is basically have manipulated. So it will be caught red-handed. Even during pre-employment checkup, those who are having a diabetes and want to get passed through medical examination that they are not diabetic, they usually become well prepared I mean, if it is less than 3 months time or 1 month time, they got a notice, they have to appear in the medical exam. They try to restrict. So they decrease fasting and plasma glucose level to make it as normal, but A1C cannot be controlled. Okay, so you must keep this thing in mind. So glycosuria Benedict test I have told you. See, in course of time in practice you will know many things. I can discuss about how much time I get. Glycosuria Benedict test. And believe me, we allow the diabetic patient to take some amount of sweet so that there will be a craze, and which I do. I have seen people are taking rasgulla and putting it like this in the shop itself. They could not resist the temptation of taking the sweets once they enter into the shop. What they can do? In the house they will not get, because wife, husband is the sufferer, wife will start rebuking, you cannot take this thing, that thing, your son, offspring will do that thing. The best way to enter into the shop and take. So because of the craze, nobody does it like this. I have seen, then I have encouraged everybody to take sweets. No, nothing is going to happen. First and foremost, you must satisfy your own soul and own mind. How many times, what are you going to do with controlling these sweets? No, I have not stopped. I have not stopped anybody. I have now never instructed anybody to stop taking sweets. Take sweets in moderation. Control as much as you can. That's it. That will ensure better compliance. Rather than if you, না আপনি সুগার কিছু খাবেন না, মিষ্টি চিনি যায় চিনি খাবেন না, মিষ্টি দই এক ভাঁড় খেয়ে নেবে, মিষ্টি আইসক্রিম খেলে পুরো কাপ খেয়ে নেবে, কিন্তু চায়ে চিনি খাবে না। হোস্টেলই হয়, আমাদের হোস্টেলে দেখেছি ফ্যাকাল্টি চা না 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 চায়ে চিনি নেই, কিন্তু দই মিষ্টি দই আইসক্রিম দাও, এগুলো হার্ডকোর ট্রুথ। আর ডাক্তাররা দেখেছি। Anyway, in low renal threshold, I have told you one point, that there was blood glucose is normal, but urine is coming. So there is basically defective transport mechanism by the renal tubules. So that is the reason low renal threshold means blood glucose level is suppose 140. 40 you are not supposed to get glucose in urine, but despite that, there is urine in the patient urine sample. So that is because of low renal threshold, means it is not normal. So there is defect in the transport mechanism in the proximal convoluted tubule, and it is by the SGL2 receptor is defective. Okay. So this part I have told you. One, pregnancy, there is a temporary lowering of threshold. Hyperthyroidism, fever, exercise is not that common. One thing I did not tell you during glycosuria case deliberately, not to confuse you. In clinical practice, remember, this part is important, note down here. In proximal convoluted tubule, there are 3 parts. One is S1, S2 and S3. In S1 part, SGLTL2, SGLTL2 receptor is there, and that absorbs 90% of glucose from the proximal convoluted tubule. And rest 10% is absorbed by the S3 compartment of the proximal convoluted tubule. Okay. So what is the difference between the two? See, look at the SGL2. It draws 1 atom of sodium along with 1 molecule of glucose. In contrast, SGLT1, 2 sodium and with 1 glucose. There is a difference. And SGLT1 is present in the intestine to absorb glucose from the gastrointestinal tract. SGL2 in contrast is present in kidney. Now, if I choose a drug which will block this receptor, what is going to happen? If I choose a drug of SGL2 inhibitor, blocker, what is going to happen? বলো 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 what will happen? গ্লুকোজ অ্যাবজর্পশন হবে না, ঠিক তো? তাহলে গ্লুকোজ বেরিয়ে আসবে, ইউরিনের সাথে আসবে, তো গ্লুকোজ লিকিং হবে, তাহলে ইউরিন অ্যাপিয়ার করবে, বেরিয়ে টেস্ট পজিটিভ হয়ে যাবে। This is a created one, not natural, and this drug is you will be using in your clinical practice. See, one is dapplazine, camaflazine, these are the drugs. See, proximal convoluted tubule, as I told you, it is SGLT2 inhibitor. Now, selective inhibition if you cause, then it will cause glycosuria. All of you have agreed? So, glucose will be basically excreted, and this drug will cause basically lowering of blood glucose, because glucose will be excreted through the urine. This drug is normally, I don't like to choose this drug, but those persons who are diabetic cannot be controlled by other oral medications, and they are overweight. Somehow their body weight has to be reduced. They are unable to reduce their body weight, then we choose this drug, so that the excess energy gets released. So there will be drastic, there will be some amount of fall of blood glucose, this body weight. That's what we want. Now it is used in the treatment. One thing you must exercise and inform the patient, maintain genital hygiene very properly, because huge amount of glucose will be excreted and the patient will suffer from genital candidiasis. You must instruct properly. You are choosing a drug which will promote excretion of glucose in the urine, and that glucose being a very good media for growth of bacteria and infection. So every time the patient passes the urine, the area is to be washed so that there is no glucose. Otherwise infection will be there. Okay, so that part you must be. So oral glucose tolerance, coming to that. So this criteria, note down this criteria. So here I have discussed about this thing. What is diabetes? Okay. So then there must be thing, it did not occur overnight. So from normal there will be a transition. So what is normal? Normal you write down here. Less than 140 glucose fasting, PP less than 140, and HbA1c less than or equivalent to less than not equivalent to less than sorry, less than 5.1, 5.7. This part has to be deleted. Write down this part. I'll try to emphasize the importance. So it is just not like that 1 rupee, a cut-off point, one cut-off point is there, 1, 2, it is not like that. So from this part to diabetes, it will take a longer time depending on how the patient is indulging or what is the genetic propensity. So it will pass from normal through impairment, IGT. So this is pre-diabetes. So 100 to 125 is the pre-diabetes, PP 140 to 199, and HbA1c 5.7 to 6.4. This you figure, you remember and memorize it. So that's the criteria. Normal fasting plasma glucose level, you say that it is 100 to less than. This you also say. What is the normal plasma glucose fasting level? So it is 100 to less than 100, 70 to less than 100. This part was not clear in earlier books. That was again one good point for my research work. A lower limit was not given. See, what I am trying to emphasize here, some of you might be in this stage, impairment stage. Now, if you exercise control, you can be brought back to the normal stage. Now, once somebody passes to the diabetes mellitus stage, despite control, it will be very difficult to bring to the normal stage. The patient will be at this stage, in the IGT stage, at the lower end of the IGT stage. So that's why I am emphasizing you that you do an yearly checkup of diabetes, all of you, without fail, so that even if you are in the impaired state, by exercising caution, you can bring to normal stage. If you maintain it, it will be in the normal stage. But from here, I am telling you, it is practically impossible to bring this stage, almost. So targets are usually made for remaining in the impaired state, lower end of the impaired state. Do you get my point? So over a period of time this will happen. Now these 2 points you note down. Proximal convoluted GFR rate is 125 ml per minute. Renal threshold is 180 per milligram. আগেরটা এই ফিগারটা লিখে এটা মুখস্থ করবে একদম পুরো, এটা কোনো রেহাই নেই, ইউ হ্যাভ টু মেমোরাইজ। এই দুটো মোটামুটি আইদার এনি অফ দ্য টু, ফাস্টিং পিপি ইউ ক্যান ডু, ফাস্টিং H1C, PP H1C, whatever way you do. Because in many places H1C facility is not there. So fasting and PP, with that thing you can diagnose this case. একটু তাড়াতাড়ি লেখো, হ্যাঁ এই 3টে পয়েন্ট লিখে নাও তো। GFR rate is 125 ml per minute, renal threshold is about 180 mg per deciliter glucose, and transport maximum of glucose TMG by the renal tubule is 375 gram per minute. This might come as a MCQ, they might be asked in the during Viva also. এগুলো বইয়ে আছে all these things, but no, হয়তো তাতে করো। What are the indications, coming to the main point, what are the indications of oral glucose tolerance test? When the blood glucose level is unequivocal, you cannot take a decision that whether the patient is diabetic or not, whether impairment or not. That is one point. Pregnancy as a routine, because today we are having 1 or 2 child ram, we don't want an abnormal baby, and if the mother is diabetic, is likely to have fetal malformation. So therefore, mandatorily, it is done during pregnancy. Epidemiological study you can do, how many percentage of diabetes is there in Bolpur or in the Birbhum district, in West Bengal, whatever way. First and foremost, to diagnose diabetes, you have suspected or impaired IGT also you can diagnose. Evaluation of glycosuria. Somebody's urine sugar was positive, you want to know whether it was due to low level threshold or something else, or whether the patient is really having diabetes, and if so, what is the blood glucose level. Third one is a mismatch between glycemia and glycosuria. Blood sugar is the blood urine sugar match করছে না কোনোভাবে। Then you want to do it, that I will show it. The main area of my research work was on this. As a routine before any surgery, without blood glucose, no routine surgery is done by the surgeon. Why? Can anybody tell? Before any routine planned surgery, a surgeon will always advise blood glucose level and kidney function test, renal function test. Blood glucose, at least minimum investigation, one investigation, blood glucose. Why? Any idea? Any idea? বলো বলো বলো, হ্যাঁ বলো। হ্যাঁ উন্ড হিলে হবে না, উন্ডটা কেটেছে বাস, সারা ঘাস শুকোবে না, ঝামেলা পড়ো। কেউ কিছু দিয়ে ব্লাড সুগার কন্ট্রোল না করে প্ল্যান্ট সার্জারি করবে না। ইমার্জেন্সি সার্জারি ইজ অলটুগেদার ডিফারেন্ট। ব্লাড সুগার কন্ট্রোল করবে, স্টেবিলাইজ করবে, নর্মালাইজ করবে, তারপর কাটবে। হ্যাঁ, দ্যাট ইজ অলসো ইম্পর্টেন্ট ইস্যু। এক্সটার্নালিতে যা হলো হলো, ইন্টারনালি উন্ডটা যদি হিল না করে 12টা বেজে যাবে। So that is important. And patient presenting with complications of diabetes. The complications suppose renal failure নিয়ে আসছে বা eye problem নিয়ে আসছে, cataract নিয়ে আসছে, তখন তোমাকে diabetes করতে হবে। And how will you prepare the patient? This is one of the most lacking point by the clinicians. They don't instruct the patient properly. How will you give the fasting sample? আরে আপনি সুগার, ফাস্টিং সুগার পিপিটা করে নিয়ে আসবেন, কিন্তু করবে কি করে? এইখানে তোমার একটা রোল আছে। প্রথমত ওকে পরিষ্কার বলে দেবে, যা খাচ্ছেন নর্মালি তাই খাবেন, অ্যাটলিস্ট লাস্ট 3 দিন। ভোজ বাড়ি খেয়ে খাবেন না, উপোস করে করবেন না। এখন রমজান মাস চলছে, অনেকে হয়তো ফাস্টিং করে, না করবেন না। এখন করলে করতে পারে, ইমার্জেন্সি হলে করে নেবে। রুটিন টেস্টিং যদি করতে চাও ডায়াগনোসিস, অ্যাটলিস্ট অন দ্য নর্মাল ইউজুয়াল ফুড অ্যাক্টিভিটি, যেটা আমরা বলি, আপনার 3 দিন নর্মাল খাবেন, নর্মাল এক্সারসাইজ করবেন, or at least 150 grams of carbohydrate যেন খায়। সেকেন্ড, ওভারনাইট ফাস্টিং ফর 8 to 14 hours, 12 hours মোটামুটি বলবে, তাহলে মোটামুটি 10 to 10 hours এর কাছাকাছি পেয়ে যাবে। অনলি ওয়াটার ইজ অ্যালাউড। লাস্ট খাবারটা খাবে নর্মাল খাবার, যেটা নর্মালি ডিনার খায়। ওই মাংস ভাত খেলাম বা একটা ফিস্ট খেলাম, বিরিয়ানি খেলাম, ওসব চলবে না। যা নর্মালি প্রতিদিন রাত্রে 365 দিনের মধ্যে 300 দিন মোটামুটি খায়, সেই খাবারটা যেন খাবে। হ্যাঁ, মাঝে মাঝে 65 দিন খায়, ও এক্সট্রা আলাদা খাবারটা খায়, ডেফিনেটলি খায়, সেটা দরকারও আছে, বাট এই টেস্ট করার আগে করতে দেবে না। প্রেজেন্স অফ ফ্যাক্টর দ্যাট ইনফ্লুয়েন্স ইন্টারপ্রিটেশন অফ দ্য রিপোর্ট, অনেক সময় ওষুধপত্র খায় পেশেন্ট, সেগুলো একটুখানি কনসাস থাকবে যে ওষুধগুলো দিয়ে অল্টার হয়ে যেতে পারে রিপোর্টটা। তো চেষ্টা করবে যাতে যদি কোনোভাবে ওষুধটাকে রাত্রেটা বন্ধ করা যায় বা সকালটা রাত্রে বন্ধ করা যায় টেম্পোরারি, বা সন্ধ্যাবেলা খাইয়ে দেবে ওকে, তাহলে একটা দিনের জন্য আপনি একটা আগে খেয়ে নিন, তাহলে ইফেক্টটা কম পাওয়া যাবে, বন্ধ যদি না করা যায় কোনোভাবে। আর যদি ইনফেকশন থাকে তখনও মাথায় রাখবে, ইনফেকশন থাকলে টেম্পোরারি ব্লাড গ্লুকোজটা বেড়ে যায়, তাকে ভয় খাওয়াবে না, বলে আপনার ইনফেকশন ছিল তাই একটু বেশি আছে, কমে যাবে, নিশ্চিন্ত থাকুন। তখন দরকার ছিল, আমি শুধু জানতে চেয়েছিলাম ইনফেকশনটা কন্ট্রোল হয়ে গেছে বা দেখুন কমে যাবে। কালেকশন অফ ফাস্টিং ব্লাড স্যাম্পল এলো, ওই জল খেতে পারে শুধুমাত্র, আর অন্য কিছু খাবার, চা যে জিজ্ঞেস করে চা খাবে, আইডিয়ালি আমি বলে দিচ্ছি চা খেলে কিছু হবে না, ফাস্টিং চা খেলে ওই চায়ের সাথে টা খাবেই খাবে, তাতে 2টো বিস্কুট খেয়ে নেবে, না না কিছু খাওয়া যাবে না, চা খাওয়া যাবে না, যে আচ্ছা চিনি ছাড়া চা একটু খাওয়া যাবে না, এই আরম্ভ করবে এইসব, তোমাকে একটার পর একটা কোশ্চেন করবে। আমি বলে দিলাম জল খেতে পারবেন, ব্যাস, একদম গ্রিন সিগন্যাল দেবে না, একটার পর একটা কোশ্চেন করে যাবে, তোমাকে কিছু হবে না। অ্যাকচুয়ালি রটি যদি কেউ খায়, ইভিন যদি একটু চিনি দিয়েও খায়, সত্যি কথা বলতে কি আপনার কিছু রেজাল্ট পেলে হেল্প করবে না, কিন্তু তুমি সব করতে যাবে না, না না জল খেয়ে করবে, একটা দিন খেয়ে নেবে না ব্লাড দেবে, তারপরে পরের দিনে খাবে চা। Drinking of 75 grams of glucose or 1.7 grams per kg body weight dissolved in 250 to 300 ml of water, জলে গুলে খাওয়াতে বলবে, এবার খেয়ে না যেন গ্লাসে, মেজরিটি অ্যামাউন্টে যেন খেতে পারে। রিমেন সিটেড, খাওয়ার পরে এইটি ইনস্ট্রাকশন দেবে, নো স্মোকিং, নো আদার ফুড ইনটেক এক্সেপ্ট ওয়াটার। এতটা খেলাম গ্লুকোজ, মুখটা একটুখানি এত মিষ্টি লাগছে, 2টো সিঙ্গাড়া খেয়ে চলে এলাম, এখানে চপ ভাজছে গরম, খেয়ে চলে এলাম, ঠিক আছে, কমন প্রবলেম। আর এই রিমেন সিটেড 2 ঘন্টা পরে বললেন তো সোনাঝুরি হাটটা ঘুরে আসি, টোটো নিয়ে বেরোলো, হাটে ঘুরছিল গেল, শান্তিনিকেতন মেডিকেল কলেজে এসেছি, দেখে নিয়ে একটুখানি ক্যাম্পাসটা, না ঘুরতে দেবে না, বসে থাকতে হবে, এখানে ল্যাবরেটরিতে বসে থাকতে হবে, মুভমেন্ট করা যাবে না। আমি শোনা যে হাট দেখুন পরে রক্তটা দিয়ে করবেন, আমি দেখেছি, আমি করেছি, আমি এসব থেকে বলছি, এটা করে খেলো, খেয়ে যাওয়ার পরে কিছু নোনতা খেতে লাগলো, নোনতা খাওয়ার জন্য 2টো সিঙ্গারা, বড় বড় সিঙ্গারা খেয়েছে, ও চপ। Collection of blood sample after 2 hours. Now, if the immediate analysis is not possible, then that blood sugar tube I have shown you, it is containing sodium fluoride. So only 2 samples are collected. There is fasting and PP. That is a mini GTT. That is a mini GTT. When glucose we have given, we are trying to see how much glucose, what is the tolerance limit. So that is the reason what is called glucose tolerance. So as I told you, this was the criteria. In classical AGDT, that's what you may be required to do, and that's what I have done nearly 400 cases. So after glucose intake, blood and urine samples are collected at half-hour interval till 2 hours to see what is the pattern, what is the rise of blood glucose level. And estimation of plasma glucose is done, and qualitative test for urine. It can be done by Benedict test, it can be done by urine deep check test also. And then you have to plot the blood glucose level and the urine sugar. So suppose this is one example I am telling you. One extra point I used to take at 2.5 hours to see what is the level of 2.5 hours, even 4 hours I have taken. And I wanted to see what is the actual response. See, you see the normal person. Normal person means fasting is normal and no value will be more than 180. All values will be less than 180. And PP value you can see this coming to 70. So at 2 hours, it should be ideally at or slightly below the fasting level, and it can be maybe higher also. So that's the normal report. And if you do the urine sugar, since the renal threshold is also normal, so all the urine sugar should be negative. In contrast, if you look at the diabetic patient, fasting level is high. PPA level is again high. Now intermediate level, you see the rise 90 to 135 to 145. What is the degree of rise? 55 maximum. Here you see the rise 170 to 270. 100 rise. So it is unable to lower down the blood glucose because insulin response is not adequate. It can be 270, it can be 370. So this level will again be 400, 500, whatever, we don't know what is the upper limit. The fasting itself is high. So if this, since it is crossing the renal threshold, so urine will be positive, urine will be positive, urine will be positive also, urine will be also positive here. Other type of curve, lag curve, elementary curve. There is rapid absorption of glucose. Rapid absorption of glucose from the intestine. You see there is 70, suddenly here you see the rise is 45. You see the rise here 70 to 220. It is sudden increase of blood glucose. Means very rapid absorption from the intestine. And then you see 190 and ultimately insulin response is very high, blood glucose level is coming down to 80. Renal glycosuria means low renal threshold. You see the level 85, 130, 130 you get the urine sugar, 140 you get the urine sugar. Ideally it should not be. So patient is not at least diabetic. So now you are evaluating glycosuria. Urine test was given, urine test was coming positive, you thought that is a diabetic case. Now while you are doing, without, now if you take a fasting and PP, it will not be able to clarify. If you do the fasting and PP in this case, whose urine sugar was coming out to be positive, you will not be able to diagnose. Now the best thing is to diagnose by GTT. And flat curve. See, their curve is, there is practically hardly any rise from 75 to 90 to 115. That means insulin secretion is very adequate. It is not allowing the blood glucose to go high up. Do you get my point? Here, it is not because of the high level of insulin, it is not allowing the blood glucose to go up. But here, because of the deficiency of insulin, blood glucose could not be brought down. The cells are unable to take up glucose, and that's why plasma glucose level is high. Is this part clear? Any question? This you try to understand. Interpretation. So if you plot it like this, so that is the 180, the cutoff point. So this will be diabetic type of curve. This is IGT, and this is normal. I am repeatedly emphasizing that if the patient is in the impaired state, by aggressive control and maintaining so, he can bring it to normal.